Hi, everyone. Welcome to the 14th episode of Dose of Derm, a dermatology guide for medical students. My name is Emma Holjak.
And my name is Iryna Savinova, and on today's episode, we will be interviewing Dr. Maxwell Sauder, a board-certified dermatologist with a fellowship in cutaneous oncology. He was previously a faculty member at Harvard Medical School and is currently an assistant professor and onco-dermatology fellowship director at the University of Toronto and Princess Margaret Cancer Centre.
At the Toronto Dermatology Centre, he is the director of the Pigmented Lesion Clinic and research director serving as principal investigator for many clinical trials. Without further ado, we are excited to introduce to you Dr. Sauder.
Thank you for having me.
Thank you for joining us. So why don't we jump right into the questions, because we are very interested in hearing your story, especially with your very niche focus. Could you tell us a little bit about your path to dermatology, how you found it, and a little bit about your schooling process?
Sure. I went to med school at McMaster, just like you guys. And when I was in med school, I tried literally every single specialty because I was curious. I wanted to experience things, and I wanted to figure out kind of what I wanted to do, right? It wasn't until the day in dermatology, or I guess it was a week in dermatology, but it was the first day of the week of dermatology where I really understood what dermatology was all about. And I should actually back up and say that my father is a dermatologist. And while he had no influence on, he did not try and influence me to go into medicine, and he did not try to influence me to go into dermatology. He wanted me to make my own decisions. And again, in med school, like I tried literally everything but dermatology up until the week of dermatology. And in the first couple of lectures of dermatology, just a light went off in my mind. And I realized that while it seemed like such a narrow specialty, it's actually extremely, extremely broad. So you could be a pediatric dermatologist in the morning, you could be a rheumatologic dermatologist in the afternoon, you could be a geriatric dermatologist the next day, you could be a surgical dermatologist in the afternoon. And so there were so many subspecialties and so many areas in which you could focus within dermatology. On top of that, one of the presenters, Dr. Moon, presented actually a case of a very close family friend of mine who was actually suffering from cutaneous squamous cell carcinoma that started on his left cheek and eventually metastasized and actually killed him while I was in med school. And he was from Hamilton, and he was admitted to McMaster Hospital and ultimately died. And he was like a grandfather type figure in my life. And so that was a very meaningful experience where I realized that that was the area that I wanted to focus in, onco-dermatology, and I wanted to help people through that situation and ideally help them avoid that situation. So, you know, I was probably a little bit late to the game in terms of trying to figure out electives and trying to get some experience in dermatology, but thankfully with some persistence and a little bit of luck with getting some electives, I was accepted into the University of Ottawa program in dermatology and had a fantastic 5 years there. And, you know, when I was in the thick of it in my residency, I'd kind of forgot that I got into dermatology because of oncology. And I was in my, it was my 4th year residency. And I had gone down to Boston to do an elective with Ruth Ann Vlagels, who is a very well-respected and well-renowned rheumatology dermatologist. So she does a lot of connective tissue disease, and I really wanted to improve my skills there. And while I was there, Ruth Ann said, or Dr. Vlagels, I should say, said, in addition to being in my room derm clinic, we have all these other amazing clinics. Take a look at the list and see what you'd like to also experience. And one of them was a skin toxicities of anti-cancer treatment clinic run by Dr. Nicole LaBeouf. And so I attended that while I was on elective, and I was just amazed and again reinvigorated with my dedication to dermatology and specifically my dedication to oncology. So that was in 2014-ish, and it was right around the time when immunotherapy was just really kind of making it mainstream in the oncology world. The first immunotherapy was approved several years earlier, and there were more and more indications coming up for immunotherapy, and we were learning more and more about the skin toxicities of these immunotherapies. And I was just blown away by the fact that there's this, incredible population of people that are going through this very intense journey that no one really wants to go through, and they are experiencing side effects that are very uncomfortable and can be treatment limiting, but they continue to want to push through because literally they have no other choice. And so if we can help as dermatologists make them more comfortable, reduce the severity of their skin toxicity, of the adverse event, decrease the incidence of this adverse event, then we can keep them on treatment for longer and hopefully have overall better outcomes. And it was an amazing experience. Dr. LaBeouf and I seemed to work well together. She had a fellowship program and I applied for it, and I was thankfully accepted into that. So after graduating from University of Ottawa, I did a one-year fellowship at Brigham and Women's Hospital and Dana-Farber Cancer Institution in Boston, and then came back to Toronto, where I started practicing. But for the first 2.5, 3 years into my practice, I would actually go down to Boston one day a week, and I'd have a clinic at Dana-Farber Cancer Institute until I started at Princess Margaret Cancer Centre, which is where I practice now one day a week doing that onco-dermatology. So I hope I answered your question. That was kind of my journey from, trying everything and then narrowing it down and identifying onco-dermatology and how I got into oncodermatology.
Thanks for sharing that. I think that there's so many different ways to get to know dermatology, and I guess our favorite way has been through people's individual story, because you kind of get to learn the many different paths that are available. Something that I was wondering was, so when you went to do that fellowship, had you already taken the corresponding states exams, like the step 1 and things, or did you not need that to do a fellowship in the States?
I did not need that in
Okay.
Boston. It's state by state dependent.
Okay.
So you just need to understand the regulations and just look into each state. I'm also dual citizen, so I'm
Okay.
American and Canadian. That may have factored in terms of my work visas. So I actually was able to moonlight in the States. So I also worked at the VA, the Veterans Affairs Hospital, as a staff down there during my fellowship year. I don't know if a Canadian that didn't write their steps would have been able to moonlight, but I'm pretty sure that Canadians are, I believe, allowed to do their fellowships in Massachusetts.
Okay, well,
Without the
definitely
steps.
something, definitely something to consider, I guess, within the path of people who are interested in exploring fellowships in other countries, including the States.
If you're exploring fellowships in the US, or if you're thinking that that's what you're going to do, if you want the most flexibility, when you're at your stage, then it would be a good idea to also concurrently write the steps,
For sure.
as daunting as it is.
What's another exam, right?
Exactly.
Kind of building off our previous question, we were wondering if there was something maybe you could think of or a specific asset that you think that your application had that helped with you being successful in matching to residency in Ottawa.
That's a question you'll need to ask the selection committee in Ottawa. But I think it was this deeply personal experience that I was able to write about with quite a bit of passion and equate exactly what my dedication to this specialty is and where I want to take my career. I will say that at least in Ontario, but I think also across the country, medical dermatology is in a little bit of a crisis. There's not enough of us that are focusing on exclusively, or primarily, I should say, medical dermatology. And so, if you can, if that comes across your genuine passion for medical dermatology, and not necessarily surgical, procedural, or aesthetic dermatology, I think that will probably go a long way in residency applications. But that's me saying it without being affiliated with any selection committee. I have no input into, residency selection at U of T at this point.
Yeah, that makes sense, and thank you for sharing. But yeah, I can imagine like being able to show how passionate and dedicated you are to that specific population, patient population, definitely probably like helps and leaves an impact on the selection committees, like regardless of where you are.
Yeah, yeah, and I would also say, I'm biased because I do medical dermatology and onco-dermatology in clinical trials. There's absolutely nothing wrong with procedural dermatology, with aesthetic dermatology. A lot of my good friends within dermatology either do a mix of all of them or are more heavily focused in some of the other areas. And there's certainly a need for that. But when I think about the residency programs and what a residency in dermatology is, the core foundation of dermatology is really built around medical dermatology.
Thank you so much for sharing that insight. I think that it's probably best that you aren't affiliated because we wouldn't want our podcast to be flagged anyway. So just genuine thoughts on your end, no affiliations needed. And kind of moving into your focus and practice in general, we would love to hear a little bit more about what oncodermatology entails. I think this may be a loaded question because it's probably such a deep field, but kind of in answering, how is it different from the skin cancer that dermatologists see on a day-to-day basis in more average clinics?
Yeah, no, I mean, Iryna, it's a great point. And so much of dermatology is skin cancer on its own, right? Like if you look at a kind of average dermatology that's in private practice in their own office, I would say if you survey 10 dermatologists that have, kind of an average practice, 50% of their time is probably taken up by skin cancers, right? So, you don't need a fellowship in that because there's an overwhelming number of skin cancers out there. Basal cell carcinoma is the most common cancer, period. Not skin cancer, cancer. It's so common that we don't even have accurate statistics on it. We only have estimates because it's not captured in any of our data registries. We think it's somewhere between 80 to 100,000 cases per year in Canada, new cases, whereas in Canada, there's probably about 240,000 cases of cancer overall. And that's across all disease sites, right? So, and that's not including basal cell carcinoma. Oncodermatology is a field that is still relatively small amount of practitioners are focusing on. In North America, Mario Lacouture has really pioneered the onco-dermatology field, and people that have followed in his footsteps, like Dr. LeBoeuf at Dana-Farber Cancer Institute, there's really kind of a handful of us that are focusing on this on a real day-to-day basis. And so what is it? It is certainly the management of skin cancers and the local regional management of skin cancers. But more and more, it's the management of skin toxicities of anti-cancer treatments. And so when a patient goes through the cancer journey, they experience a multitude of anti-cancer modalities, right? Maybe it's surgery, maybe it's radiation, maybe it's medical treatments, such as traditional cytotoxic chemotherapies, targeted therapies, immunotherapies, hormonally based therapies, stem cell transplants, right? Organ transplants. So there is a multitude of interventions that occur, and any one of them will have implications and long-term sequelae on the skin. Some of them have higher incidences than others, right? So for example, with immunotherapy, which is used virtually now across every tumor and across more and more stages of types of tumors, immunotherapy doesn't turn down the body's immune system like traditional cytotoxic ones would, or target kind of non-specific rapidly dividing cells like traditional cytotoxic chemotherapies. What it does is it unleashes the body's immune system. So it cuts the brakes to the body's immune system. The problem is we often overshoot the mark. And so when we overshoot the mark, we get inflammation of virtually every other organ, right? So we can get thyroiditis, we can get pericarditis, we can get pneumonitis, we can get colitis, we can get hepatitis, we can get hypophysitis, we can get dermatitis, and I'm putting that in quotes because all our listeners can see that right now, I'm sure. So you get a multitude of inflammatory skin diseases, but they're skin diseases that dermatologists see on a day in and day out basis. It's dermatitis such as pruritus without any primary dermatologic findings, eczematous eruptions, lichenoid eruptions, psoriasiform eruptions, bullous eruptions. And so when the patients get these skin toxicities, no matter the disease site, it's usually a positive prognostic sign that the patient's actually responding to the anti-cancer treatment. So it means that it's the exact opposite time to actually stop the treatment, or hold the treatment or reduce the treatment. But B, because they're uncomfortable, that's an opportunity for dermatologists like myself that are focused on oncodermatology to come in, identify what this eruption is, figure out a way to manage the skin concurrently without compromising the anti-cancer effect of the intervention, so that the patient can stay on treatment, ideally without dose reduction and ideally without dose interruption, so that they can continue to respond to this treatment and hopefully get lasting anti-cancer effects, which is often what happens in immunotherapy. So it's really managing the quote unquote rashes that people get from oncology treatments.
That's super interesting. And thank you for sharing that. I think that when you hear oncodermatology without having done like a Google search beforehand, you maybe kind of make assumptions on what the field is. But this is definitely, I think, different than what people expect when they first hear the name, and very important, clearly, because it helps patients stay with their treatment plans as planned, as opposed to quitting early because of those extra manifestations or very likely uncomfortable skin manifestations that go along with it, from what I'm understanding.
Yeah, absolutely. And by the way, I love that you're Googling oncodermatology, just like 9 out of 10 of my patients that come into the office that have Googled what what they have.
What does that mean? Yeah.
Exactly. Yeah. Yeah. No, but it's it's a small field, it's an evolving field. There's more and more of it in the literature, but one thing that's really nice about being involved in a very small field is that there's a small international group of us. So when I go to national or international, mainly international conferences primarily, there we often get together. And so, the North American onco-dermatologists, we can all fit into a room. And even when our European colleagues come to our meetings, and they're invited, again, it's a small community. And so we often try and collaborate with each other across multiple institutions. And I've been fortunate enough to do some of those cross collaborations. And it's also great for us to collaborate with industry, particularly now more and more with getting involved in helping trial designs with managing their skin toxicities in terms of protocols, what's included in their protocol. So now more and more industry is thinking of, okay, we know that this drug is going to cause some skin toxicities. And so how can we manage it to minimize it? And how can we be tracking that and identifying that not post-drug approval, but while we're actually testing the medication, which I think is fantastic. And it's, kudos to those that have come before me, those that are more established than me in the oncodermatology space that have really made industry aware of the importance of this.
That was really interesting. Thank you so much for sharing. The next topic we have is maybe a slight pivot. We were wondering, and it's kind of also a big question as well. We would love to hear your perspective or your insight on what you think the biggest issue facing the field of dermatology is right now.
So now I'm going to put on my political hats. I am a board member of the Canadian Dermatology Association. I'm not speaking on behalf of the Canadian Dermatology Association, so I just want to make that clear. I'm also currently part of the section of dermatology, OMA section of dermatology. And again, I want to make clear that I'm not talking on their behalf. I'm just talking as an individual, just from a disclosure perspective. But I do think that there are two main issues that I think that most of us dermatologists would agree on. Number one, I already alluded to, is that medical dermatology is in a little bit of a crisis, mainly from a supply and demand perspective. There's a huge demand for medical dermatology of people suffering with significant skin disease, whether that's cancer or whether that's, chronic debilitating conditions with multiple comorbidities such as atopic dermatitis or psoriasis or prurigo nodularis or, rarer conditions like autoimmune blistering conditions. And for a variety of reasons, there is a diminished supply of dermatologists that are willing to focus in these areas and to see these complex patients. And, quite frankly, part of that is a big part of that is the government's lack of support with regards to appropriate remuneration for these complex medical patients. We are making improvements in that area, and the government has made improvements in that area, which is fantastic, but it's a small step. So I think that that's a huge issue, and there are so many layers to that, and there are so many things that come with it. There are so many reasons for it that we could dedicate 10 more of your podcasts to that, which I'm sure no one wants to hear me rant about this. But, again, the bottom line, medical dermatology. Part and parcel with that is the issue of encroachment, which is where other physicians present themselves as doctors of the skin. Not necessarily dermatologists, but for example, family doctors that may do some additional training that then restrict their practice down to only seeing dermatologic cases. And I'm not saying that's good, I'm not saying it's bad, but it's an issue, and it's an issue that has stemmed from my first issue, which is the lack of access to medical dermatology. And so, it comes down to organization of the medical system. And yeah, I think that those are the two big issues. Medical dermatology is in a crisis, and other practitioners managing skin conditions, which may be appropriate in a lot of situations, but can probably be improved in the way in which we are doing it to provide greater insight so that patients get the optimal care.
Yes.
Is that a whole big can of worms? Am I going to get in trouble for anything that I just said there?
No, it's just we're having an open discussion. I think that's completely fair to think about. Now, with that kind of big question in mind, and with all that being said, we know that most of our listeners are interested in dermatology. So we wanted to ask you what you think that everyone who is applying to dermatology should know before they apply.
What everyone should know before they apply. We are not just pimple poppers. So it's funny. I had a phone call today, just non-medical related, and someone asked me, the person asked me, what do I do? And I said, well, I'm a dermatologist. And she said, oh, can I ask you a strange question? Do you love popping pimples? And I'm like, oh God, that's exactly what I hate the most, of people asking me. Not that there's anything wrong with it, again. So I'm sorry, what was the question is what
do you think that everyone pursuing dermatology should know before they kind of make that step in committing to the field?
Yeah. I'm going to go back to medical dermatology, right? I hear a lot of young students, and not necessarily medical students, but like even younger, that are in high school. They come into my office and they say, or their parents say, oh, they want to be a dermatologist when they grow up, right? I want people to know that there is a huge amount of medicine involved in dermatology, right? So the first 2 years of my residency in Ottawa, I actually, if you add up pediatric medicine rotation and internal medicine rotation, I was on the floor more than an internal medicine resident for the first 2 years. Now that's a little bit unique to Ottawa because we did a lot of we did a couple pediatric floor rotations, but that's something to know, that basically for PGY 1 and 2, you are essentially an internal medicine resident. And so my backup, if I didn't get into dermatology, was internal medicine, because I do like a lot of medicine. I love the mix of medical and also procedural medicine. And so I thought that, okay, if I couldn't do dermatology, then maybe I'd go into, the ICU or something like that. So I think that that's the biggest thing, is that it's not just Botox and fillers, and it's not just lumps and bumps, but there's a ton of medicine involved in dermatology.
I think that is a great piece of advice, because that might honestly be something that people might not realize how much time you really do spend training in like internal medicine and like generalist hospital medicine until they maybe go and look at residency program structures. So that's a
Yeah.
great tip.
Yeah.
And I think we kind of touched on this a little, but we
Yeah.
were wondering what your favorite and least favorite parts about dermatology are.
So my favorite parts of dermatology are really the relationships that you develop with your patients, especially the ones that have significant skin disease or are going through an incredibly tough cancer journey, right? So I do a lot of clinical trials, and I use a lot of systemic medications to manage things, as I said, such as atopic dermatitis. And I guess I've been practicing in Canada for 7 years now, and seeing how we can change people's lives for the better when you control their skin disease, seeing how, treating a grade 10 student with severe atopic dermatitis that the year before seeing me missed a third of the academic year because she was unable to attend, because she wasn't able to sleep the night before because she was so itchy, and then getting her skin under control and having this individual go from a C level student to an A student, and then see her get into the university program of her choice and watch her continue throughout her academic career, it is exactly why I got into dermatology. And there's significant skin disease out there that we can make meaningful impacts on. I just saw a young man today who's 27 years old, and I was introduced to him about 3 months ago, and he's had atopic dermatitis his whole life. And when I saw him, I was actually screening him for a clinical trial, but I didn't realize that he was actually on prednisone at a significant dose. He was at, I think, 25 milligrams at that point, and he had been on it since August, and I was seeing him in October. And so you can't be on prednisone for this protocol to get onto this clinical trial. And you also can't stop someone on prednisone who's been at that dose or higher since for the last 2-3 months. So I tapered him off prednisone appropriately. I optimized his topical treatments, and then I saw him back actually today. And today he still had significant eczema. When I asked him over the last 3 days on a scale of 0 to 10, 10 being the worst itch you've ever had, 0 being no itch whatsoever, what would you say you're at? And he was a 6 out of 10. And that is uncomfortable. And then I asked him on a scale of 0 to 10, 10 being not sleeping at all, 0 being sleeping no problem, over the last 3 days, how has your sleep been? And he said 8 out of 10. So this guy's not sleeping. He's uncomfortable, and he's working right now, but he's probably not being as productive as he could be. And so now he's off all the prednisone, but we're going to start him most likely on a biologic. And I told him as we were finishing up the visit that this is going to change your life in a positive way. And we're going to hopefully get you to a point where you're able to sleep through the night, you're able to feel rested, and you're no longer worrying about your skin or when it's going to flare or how itchy you are, and you're just going to be able to focus on you and your potential and be as productive as you can at work. Because yeah, I've seen it, right? So again, what's my favorite thing? Seeing people go from, a very bad place to them being able to meet their potential and exceed their potential in life. And my least favorite thing is popping pimples. And honestly, I&D of cyst, it's messy. Even when I still wear a mask and it smells.
Well, we appreciate the candor. There's clearly ups and downs, but thank you for sharing those stories. It got me thinking that sometimes when we're on this side of medicine, it's easy to forget how debilitating things like itch or even pain can be. And something that it reminded me of is when people say, when I get a stuffy nose when I'm sick, I think back to all those times that I never appreciated being able to breathe. And here again, you think about that one time you get a mosquito bite and that itch, takes over your life for those next 2 days. And now you reflect on how patients experiencing this every day for months might feel, and you can kind of start to put into context.
That's exactly it. Think about that from childhood,
Yeah.
right? Like, yeah, it's I mean, again, that could be another podcast, but I do think that atopic dermatitis is still an underserved disease for a variety of reasons, including reimbursement from our government. Not that I'm anti-government, I'm just saying that there is not as equal access to, Health Canada approved medications in Ontario for patients with atopic dermatitis as there are for patients with psoriasis. But that's a whole other different can of worms. But it's a disease of childhood. It's a disease that can have significant impact on the individual, but also the entire family. When you have a pediatric patient, it is not just a disease of the kid. When the kid's not sleeping, I can tell you as a parent myself, you are not sleeping, right? And so then, the parent isn't at their best. So, that's one area that there have been enormous strides in the last 5 years with the approval of 5 Health Canada medications, more to come, but we still have a lot of work to do with atopic dermatitis.
Well, it just kind of opens up the field for any newcomers who want to explore that area of research, I guess, as a positive.
Absolutely. Absolutely.
Okay, well, thank you so much for sharing all those insights and sharing your story a little bit with us. To end off the episode, as we mentioned, we like to ask our guests some rapid fire questions to allow our viewers to get to know you a little bit outside of medicine. So the first question we wanted to ask you was, besides anything technology related, what is one item you can't live without?
My wife and children.
Okay. You know what? That's fair. We didn't factor that in. That's a very valid answer.
Probably my 3 most important things in life.
That makes sense. And it's great to hear. I'm sure they're going to love that answer as well. And then the next question that I wanted to ask you is, what was your favorite part about living in Boston when you were there for your fellowship?
So I'm a huge Boston Red Sox fan. My family's from Boston originally, and so there was a rumor in my family that allegedly my maternal grandfather played semi-professional baseball for the Red Sox. So when I was growing up, the Blue Jays were a very competitive team, and the Red Sox weren't quite as competitive. And despite the Blue Jays winning the World Series in 92 and 93, I was like one of the only kids that was cheering for the Red Sox. And so being able to, be within walking distance to Fenway Park and go see baseball games at Fenway Park on a pretty regular basis was amazing. My wife and I were at David Ortiz's last baseball game, which was a playoff game. And actually, my unborn daughter was attending that game as well because she was in my wife's abdomen. And then we took my daughter to her first baseball game. She was 8 months at the time. And Boston on Marathon Monday. So when the Boston Marathon's being run, it's the only game in baseball throughout the season that has a start time in the morning. So one day a year, every Boston Marathon day, on that, it's always a Monday, Marathon Monday. The Red Sox play at Fenway Park at 11 a.m. And so we took my daughter there for her first baseball game, which was pretty amazing. So definitely being able to see the Red Sox on a regular basis.
That sounds very special. And kind of shifting to our last question, which is nothing like the question you just answered. And it's one of my favorite questions to ask. So I hope
this is
you
a
have
lot
an
of pressure here.
answer. Yeah. My question is, what is your favorite condiment? And you can think broadly to like even
mustard,
maple syrup or sprinkles.
Mustard
over sprinkles?
Yeah, no, mustard.
Mustard.
Yeah.
Okay. Are you the yellow, regular Canadian mustard kind of guy, or something fancy like Dijon?
No, nothing fancy. I like the French's mustard.
Okay.
Yeah, It's just, I don't know why, like it was so easy. Like when I think of what I put on a hot dog, it's just mustard. Yeah, I don't know. Um, it's no fat and no sugar also. Not that like I'm, a calorie counter or anything, but like, yeah,
I guess you can add it to anything. I know that there's a new trend now of adding olive oil to ice cream. So maybe you should try mustard on ice cream and let us
interesting.
know how it goes.
There's also olive oil in coffee as well.
Oh, I haven't heard
Yeah,
that one.
yeah, it's based out
Mm,
of Italy. Starbucks was trying it actually in some of their locations in Italy.
okay.
Yeah.
I mean, I guess
Um,
if
but
it's Italian,
I've
you can't
definitely,
knock it.
yeah, I can remember in med school, when I was scrounging around for dinners at night, and I may or may not have been making like chicken fingers or chicken nuggets. The condiment of choice with that, mustard.
Okay, that's not bad. I thought you were gonna say you were making mustard crackers or something more.
No, I haven't done mustard crackers yet, but now you got me thinking, so maybe I'll need
There
to
you
try it later tonight.
go.
Yeah,
Sounds great. Well, on that note, I wanted to say a huge thank you to you, Dr. Sauder, again for taking the time to join us. And to all our listeners, thank you so much for listening. We hope you enjoyed this episode and learned a little bit more about oncodermatology today. If you want to keep up with our podcast, offer any feedback, or know when we post our next episode, you can follow us on Instagram or Twitter at Skin Curriculum, or visit our website at www.skincurriculum.com. Otherwise, we hope you enjoyed this episode of Dose of Derm, and we hope you all take care.